Overjoyed to welcome everyone today to our Ask Me Anything with Dean Jha around the COVID-19 vaccine. We'll be going over the next hour through a number of questions that the community has submitted in advance, as well as questions that you all have the chance to submit during the event. There is the chat function and the Q&A to submit questions in real time. I will encourage you guys to submit your questions using your name. Ashish and I both care deeply both about knowing who it is within the community who's asking and making sure that we all have the chance to ask and get answers to our questions with no judgment. This is a chance to really help the larger Brown community dispel myths, get answers to things that are still unclear, and to move us more towards a shared understanding of what the COVID-19 vaccines are, how they protect us, and what the next steps are going forwards, both within the Brown community and the larger world. So with that, I'll turn it over to Dr. Jha.
Great. Good morning, everybody, and thank you all for being here. Let me just get this clicked off. So I'm going to speak for about 3-4 minutes, and I just want to kind of lay out where we are with these vaccines, why I'm very optimistic about the future, and kind of hit on some of the questions that I get asked. As many of you know, I get asked questions about the vaccines about 10 to 12 times a day. And I'm going to hit on what I think are some of the most common questions I get asked. We've had about 150 questions pre-submitted. Obviously, we're not even going to get to a large chunk of them because we don't want to just do pre-submitted. We actually want the opportunity for many of you to ask questions through the live session. And really, the only rule I want to put on the table is there are no bad questions. I mean, you'd be surprised, even from close friends and family, the kinds of questions I get asked. There's a lot of confusing information out there. And so please, please, please don't be shy about asking questions, and we will try our best. I'll try my best. Megan and I will try our best to answer, get to as many of those as possible. Big picture, where are we with vaccinations in the United States and globally? Globally, we've administered about 1.3, 1.4 billion doses of various vaccines. In the United States, we're getting close to about 300 million doses administered. So that is a remarkable number of vaccine doses that have been delivered and administered to about 165 million people in the United States. So more than half, or about half of all Americans have gotten at least one dose. About half of all adults have gotten both doses. And this is the biggest vaccination program, certainly in the history of the United States, but actually not just in the United States, in the world. We've never vaccinated this many people this quickly for anything. And of course, the reason is because we're in the middle of the worst health crisis in a century, and that's what is driving it. So what do we know about these vaccines? And again, all the vaccines are a little different. And I'm going to keep all my remarks to focus on the 3 vaccines that have been authorized in the United States. I'm happy to get into talking about AstraZeneca and Sinopharm and Sputnik 5, the Russian vaccines, but they are largely not pertinent to us. They may be pertinent to some of the international students, and we can talk about that in the Q&A. But when I look at the 3 American vaccines, Moderna, Pfizer, there are the 2 mRNA vaccines, and then Johnson & Johnson is the adenovirus vaccine. All 3 of them are way better than what I expected them to be when I was thinking about this last summer. Last August, I had a one-on-one kind of discussion with Tony Fauci. Many of you may have participated. We both talked about our hopes and aspirations for the vaccines. These 3 vaccines have far exceeded our expectations on effectiveness. What do we know about the safety of these vaccines? All 3 of them are exceedingly safe by every measure that we can think of. And so obviously there are the short-term side effects that these vaccines generate. But now we have experience on literally hundreds of millions of people having gotten these vaccines. You've heard about the J&J vaccine and the issues around blood clotting. We're still trying to get an exact number. It probably depends on who you are, your demographic. The risk may be as high as 1 in 100,000, maybe as low as 1 in a million. But even that is exceedingly rare, and we have not seen that with the mRNA vaccines. Last kind of 2 quick points I want to lay out, and then I get into the question. The 2 things I probably get asked most often. One is, I'm worried about the long-term effects of these vaccines. What do we know about the long-term effects? And it begins, the answer to that question, I mean, the short answer and the simplistic answer is, well, we haven't had these vaccines for for a decade, so we don't know the long-term effects. But the more sophisticated answer is to ask the question, how do these vaccines work? And is there a plausible mechanism by which there could be long-term effects not seen in short-term periods? And what do we know about other vaccines, and do they have long-term effects? Well, we've been vaccinating people for a long time, and it depends on when you want to set that timer, but certainly we've been making vaccines and giving it to people for well over half a century. There is no vaccine that I am aware of where the first set of negative effects show up past 8 weeks after vaccinations. Just has never been one. And if you understand the biology of how vaccines work, it wouldn't make sense that somehow 5 years later, a new side effect will show up. That's sort of not how vaccines work. So it's biologically implausible that you're going to get an effect for the first time 5 years later. And the history of vaccines suggests that almost all of the side effects, almost all of the problems that vaccines generate, and vaccines are like every other thing, they're not 100% like safe because you always have some risk of some side effects. But all of them tend to show up usually within 2 to 4 weeks, sometimes earlier. And there are 1 or 2 instances where the side effects have not shown up until 6 or 8 weeks later. I'm not aware of anything that gets beyond 8 weeks. This is why the FDA, when they were thinking about issuing an emergency use authorization, asked for at least 60 days of follow-up because it gets beyond the 8 weeks being 56 days. And that's why the FDA authorized it with 60 days of follow-up. Now we have more than 6 months of follow-up in millions of people. Last point I want to quickly raise is a question that people bring up a lot of EUA versus BLA. BLA is the full license, EUA is emergency use. People say, well, if it's still under emergency use, how do we know it's safe? So the EUA was issued because at that time, we did not have enough follow-up data. We were in the middle of a crisis, and it made sense to issue an EUA. I expect over the next month, Pfizer will get the full license, probably in the month that follows. Moderna will. Johnson & Johnson will take a little bit longer. These vaccines have been studied with more data and more evidence than any vaccine that has gotten full licensing. There is no question they will get full licensing. It's just that you want to have enough follow-up, 6 months of follow-up with large enough populations. And so that's all coming. But yes, while it still remains under EUA, if you actually just care about the underlying scientific data, there's way more data on these vaccines than any vaccine that I can think of. Maybe again, except for the polio vaccine, for which we've got more data over many, many years. So I think we feel like we have a lot of confidence on a lot of these kinds of issues. And I can keep talking, but why don't I stop and see what questions are coming in, what questions have come in, and I will let Megan drive the ship. Megan.
Thank you, Ashish. Terrific overview. Really appreciate it. So we are getting questions fast and furious. Really appreciate it, folks. I'm going to be combining some questions, but I will include your names, as I mentioned, so that you can know that your questions are getting answered. So the first question that I'm going to ask comes from Joanne. And it's specifically around Brown, but I think that we have a number of other related questions that expand beyond the Brown space, which is, if all faculty, staff, and students are required to be vaccinated, will we be able to return to work and move about freely in the building without masks? I have other similar questions from other folks about kind of the related question of, once you're vaccinated, talk about going out in public without masks.
Yeah, great. And so let me actually give one small caveat, and then I will. So I was not formally involved in the creation of the Brown policy. Brown policies are being developed by a committee of physicians and public health people and senior leaders of the university. And but as you might imagine, I have my views on this, and I have shared them widely with the university leadership. And all the policies I have seen so far, I think are right and consistent with my world views. And there's going to be more coming on this in the upcoming days in terms of relaxation of a lot of the restrictions we had. So I will tell you where I think the science is and where I think we will likely land at Brown. But some of this is still being worked out, and I don't want to presuppose where the committee lands. Once we have enough people fully vaccinated, and so that's going to be the key issue. Once we have enough people fully vaccinated on campus, life is going to get back to pretty close to normal. Are you going to be able to be in meetings with other people unmasked? Absolutely. Are you going to be able to move around the building unmasked? Absolutely. When? there will almost surely be a threshold effect. There's a bunch of issues to sort out of how do we verify that everybody's fully vaccinated, right? So there's a bunch of logistical stuff to be sorted out here. And the committee is working really hard on getting all of that right. And again, that's the part I don't want to jump ahead of. But I feel very clear that once we meet those thresholds and figure out those logistics, absolutely, I will feel very comfortable having meetings in my office with people who I know are fully vaccinated. Mask wearing. We may do mask wearing in tight quarters if imagine there's a faculty meeting and it's 100 people cramped into a room. I don't know if we're going to even do those, but if we did those, that might be a reasonable time with that many people. But if everybody's fully vaccinated, you could argue you don't even need to do that. So I think there will be edge cases that we're going to still be sorting out, but the standard will be if enough people are vaccinated, everybody's back on campus, life will go back to some version of normal.
I love that. And as a disclosure, right, Ashish, you and I have been getting together without masks for a bit now because we are both fully vaccinated, which is a lovely thing. So thank you. Another area where we're getting a whole bunch of questions is around folks who took one kind of vaccine and then want to know what happens if there's another one. So we've got questions from Nitin, Kathy, Solange, Kushagra, some of whom say I took the J&J vaccine or I took the AstraZeneca vaccine in another country, as that was the one available earliest for me at the time. When will it be safe for me to shift to one of the mRNA vaccines? Is it safe to switch to a different type of vaccine? How do we handle that mixing of vaccines, and where do we think it's going?
Yeah, so this is one where the science is a little bit thinner. We just don't have as much data, but we do know a little bit about how vaccines work, and we know a lot about how vaccines work, so we can also make some reasonable scientific judgments. So if you've gotten, and again, a lot of this is specific, right? So if you've gotten the J&J vaccine, there is a trial going on right now of 2 doses versus 1 for J&J. I think those trial results will probably come in late summer, early fall. It may be that a second dose of J&J is better than having just one, and you may decide at that point that you want to get a second J&J vaccine. That would be, in my mind, a very reasonable thing to do. And I think if you've got a single dose of J&J vaccine, you really are quite protected. And I'm happy to talk about why I think the J&J vaccine continues to be underappreciated in terms of its efficacy. But that's kind of one issue. People who have gotten the AstraZeneca vaccine, which you could not have gotten in the United States, it's not authorized. But let's say you got it in the UK, you got it in India, you got it in one of the many countries where it's been authorized. And then you come back to the United States and you want to get a second shot. You can't get AstraZeneca. Could you get a Pfizer or a Moderna or a J&J? There are a couple of studies now that are out on this. The best one is from Spain. I think the second dose was with Pfizer. And the short answer is it looks like it does even better than just 2 of the same. And there is a good theoretical basis for saying maybe mixing may be better than going alone. But that's a theoretical basis. So first of all, just be very clear. If you're in the US, you've gotten one, get the second of the same kind. Like, don't start mixing on your own because you decide, hey, maybe it's better. Like, if you got the first shot of Moderna, get a Moderna second. If you got a Pfizer first, get a Pfizer second. There's a theoretical benefit of mixing. The data so far is thin, but seems to suggest that it's at least totally safe. You get a nice response. You may get a bit of a better response. We don't know that, but that will come out more over time. But I suspect that we'll get to a point we'll feel pretty comfortable mixing doses.
Thank you. And I'm sure lots of folks have seen the reporting around the evidence about mixing of natural immunity with vaccines actually gives you a much stronger response, according to some preprints that just came out yesterday, which then takes me to another question, which lots of people have been asking about, which is this idea of boosters. Shantae, Stephanie, Destry ask about, do you think a booster shot will be required for any or all of the vaccines received? Sarah Walker, I keep hearing about the booster shot that might be required in the future. What are your thoughts, Dr. Jha?
Yeah, I wish people would stop talking about boosters. The questions are great. I don't mean I wish people wouldn't ask me. You're asking the question because a lot of people are raising the idea of boosters. It's a totally reasonable question. Most of the talk about boosters are coming from the leadership of Moderna and Pfizer. There's a complex set of motivations that they have for doing this, and I'm not going to get into all of that. I will say the following. I've seen no data that suggests people are going to need a booster anytime in less than a year from their final shot. It is possible we may not need a booster for even longer than that. Of course, it is theoretically possible we may need one sooner. We get some new variants that really start generating a lot of immune escape. I think that's unlikely. It's not impossible. We may get some new data that suggests that vaccines don't last as long as I think they will last. My expectation is these vaccines will give you very strong levels of protection for at least a year and possibly much longer than a year. We don't know, and that is still being investigated. But I would not, the chances, so I got my second shot at some point in February. The chances that I will need a booster this year, I think, is exceedingly low, but not zero. And I spend literally no time thinking about it. If science emerges that shows that we do need one, we'll talk about it. But I wouldn't plan on it. I think the university shouldn't plan on it. And I think we should just move forward expecting that there's a pretty good chance at some point in 2022, we'll all need boosters.
Thank you. So I've gotten another group of questions specifically around kids. Well, so I should say around kids, around pregnancy, and around lactating women. I'm going to split them into two groups. The first is for kids. Kimberly, Emily, Michelle, I'll ask, is the vaccine safe for children and teenagers? And why was the age of 12 chosen for a cutoff?
Yeah, good question. So we have pretty good data on 16 and 17-year-olds from Pfizer. Now millions of 16 and 17-year-olds have gotten vaccinated. And we have exquisitely good safety data on that. And by the way, the reason that was the first group was because Pfizer was tested in 16 and older, and Moderna was tested in 18 and older. So the authorization was, there's nothing about Pfizer that makes it safer in kids than Moderna. And I actually think we're going to get authorization for kids in Moderna too. It's just how the clinical trials were set up. The clinical trials also really focused on symptomatic disease as the primary outcome. And we know kids have less symptomatic disease. So part of it was they were trying, remember, mind shift to June, July, August last year. We have these vaccines, they look like they're generating good immune response, but we got to figure out, are they actually protecting people from infection? These clinical trials were set up to go fast and get as many people enrolled and to try to show outcomes reasonably quickly, because we were in the middle of a global health emergency. And so they decided, and I think this was the right decision, I would have made the same decision, not to test it in kids first. Kids tend to be less likely to, well, they may be a little less likely to get infected, but they're far less likely to get sick. And so that's why they were excluded initially. Okay, we did the studies, we got data, looked like it was pretty safe in 16 and 17-year-olds. Where do you go next? Pfizer and Moderna both said, all right, we're going to go for the next crowd. And the next crowd is to reduce that age down, and they went to 12. Nothing magical about 12. It could be 12, it could be 13. But they were, and biologically, and this gets a bit more complicated, 14-year-olds a lot more like 16-year-olds. 4-year-olds are probably are clearly different for two sets of reasons. Physical size, you need to come up with a different dosing for a 4-year-old than you would for a 14-year-old. And second, the issues around puberty, and they're just sort of biologically a bit more similar. So that's why they've gone for cutoffs that they have. The next set of data are being looked at in kids under 12. So it's a pretty classic thing to do in vaccines. You start with the high-risk groups, which is adults, then you go for kids. And because not all kids are the same, a 17-year-old and a 2-year-old are dramatically different biologically, you start with older kids and you work your way down. That's essentially what these guys are all doing. And now studies are ongoing for under 12. By the way, there is new data out on Moderna for 12 to 17-year-olds. It looks really, really good. And therefore, I think Moderna is going to get authorized for kids as well.
Thank you. And I think kind of one thing that wasn't asked in the questions, but is related, that I know that you and I have both gotten questions about, is if you have a small 12-year-old, it is okay for them to get the full dose. It's not a weight-based dosing. It's really more about kind of age and development of your immune system.
Yeah.
Right. So a related question is about lactating women and pregnancy. Angela and others ask, have there been studies regarding safety in lactating women? How about pregnancy or women trying to conceive? Can you talk about the vaccine safety there?
Yep. So let's talk about, they're just different groups. Let's talk about 3 different groups: lactating women, pregnant women, issues of fertility, and women wanting to get pregnant. All right. Let's talk about pregnant women first, because that there, I would say we have probably the most amount of data. So first of all of this stuff, like, we're getting data all the time. So clinical trials are ongoing, and they will be for years, right? Because we're just going to always want to be collecting more and more information. What we know is that lots of pregnant women have gotten vaccinated. We have seen no safety signals in terms of bad outcomes for the women themselves or for babies. And basically right now, we think about 10,000 pregnant women at least have gotten vaccinated. And all of the studies that have followed them so far look really good. There are larger trials ongoing with NIH. But there's a flip side to this story, which is what happens if you get COVID while you're pregnant? And pregnancy is a pretty substantial risk factor for bad outcomes from COVID. So at this point in the pandemic, if you're a pregnant person and you're trying to decide what is safer, all the data on the vaccines look exceedingly safe. All the data on what happens if you get COVID look really not that great. And so the risk-benefit calculus here, in my mind, is a no-brainer. And I have been saying for months now that if I had a pregnant woman ask me, and I've talked to lots of people, I would say very clearly that people should be getting vaccinated. Because again, and they have, and the safety signal there is pretty good. On lactating women, I think the data is less good in terms of what we know, but all of the data so far suggests that the antibodies that people generate is passed on through the breast milk and may offer a level of protection to the baby. I wouldn't say that data is nailed down. There's been no data whatsoever on adverse effects for lactating women or on the baby. But the data suggests that there is, as there is with a lot of different antibodies. And so you may be offering a level of protection as well if you're pregnant and vaccinated. But I don't want to overstate that benefit, because I just would say that we don't know that much yet. The big issue that I want to make sure we spend a couple of minutes talking about is fertility, because it is not random that there has been a lot of misinformation about fertility. It is, in fact, and you may know, there's a really nice article in the New York Times yesterday, I think it was the Times, not the Post, but one of them, about a group of people who have been basically spending enormous amounts of money trying to spread misinformation about vaccines. And they don't pick random topics, right? Like, they don't start a campaign saying if you get vaccinated, your right leg is going to fall off. Because A, it's verifiably like not true, and people are going to like know immediately that this is junk. So they tend to pick things where there is anxiety, where there's concern, where it's harder to verify. And that's what has happened with the whole very well orchestrated misinformation campaign around fertility. So let's talk about what we know. No vaccine has ever been linked with infertility that I'm aware of. And there is literally zero evidence that any of the three vaccines will cause problems with fertility, or has caused problems with fertility. And again, we've had hundreds of millions of people get vaccinated, including lots of people of childbearing age. What's the misinformation? Well, you always sort of get people who do this stuff, those who spread misinformation and disinformation, usually take some small piece of data or information out of context and then blow it up. There is a protein found in placenta, Synctin-1, that they claim looks a lot like the spike protein. Not really. It shares 4 common amino acids. There are hundreds of proteins in your body that share more common amino acids than that. And so you can take one piece of fact, it shares 4 common amino acids. That sounds bad, except literally, if that alone could generate a autoimmunity problem, these vaccines would just be unbearable and intolerable in people, because people would be having autoimmune issues all the time. They're not. So this is, I get the concern. People obviously are following this very, very closely. Lots of people looking at this. I remain unworried because there's no biological basis for this. It has never shown up in other vaccines. And therefore I remain very confident. And I will tell you, on a personal level, I have 2 teenage daughters who have both gotten their first shot. They haven't gotten their second yet because they're under 16. And so they just became eligible, but they'll both get their second shot soon. And this is what I'm recommending for all my friends and family. If I had an ounce of concern about this, I certainly wouldn't be doing it. I remain pretty convinced that this misinformation campaign ultimately will fail because it's not really rooted in science.
Thank you, Ashish. Thanks for addressing that. It is, I think, a common issue that everyone has heard. One other little tidbit I will add there is that there are actually some signs that COVID itself may temporarily decrease sperm counts. So if you're worried about fertility, don't get COVID. It's kind of the best possible advice. A related question, one final question on kind of the kid topic, at least for now, is that there were a few people who've asked about return to work with a baby at home. And there's various kind of variants of this question that have come through both in the pre-questions and today. Is there a risk to unvaccinated small children or babies if their parents are required to go back to the office and the workplace doesn't require vaccinations? Also questions about taking your kids and babies out in general, given that they're unvaccinated. Can you talk about that?
Yeah. So let's start from the several different scenarios there. So let's start with the scenario of you're fully vaccinated and you're in a fully vaccinated work environment. So actually, before I even do that, let me take one step back. Kids under 12 are not vaccinated, and they are unlikely to be vaccinated in the next few months. I mean, I'm hoping maybe early to mid-fall. Could be earlier than that, right? I've been surprised at some of the pace of some of these things, but it could even be later than that. So what's the best way to protect kids under 12? Let's answer that question first, because then that will lead into all of these. The single best way to protect kids under 12 is to make sure people around them are vaccinated. Like, that data on that is overwhelmingly clear, because what happens is essentially you create a ring of protection around kids. I think about my family. I've got a 9-year-old, I've got a 14-year-old, and an almost 16-year-old. My 9-year-old isn't vaccinated and is not about to get one anytime soon. But the best way we have to protect him is the fact that his parents and now his 2 older sisters have both gotten vaccinated. Now you say, well, what about other kids? No, other kids obviously are not vaccinated, his friends who are 9. But we live in a community with high levels of vaccination, has dropped infection numbers way down. And the other kids' parents are vaccinated. And that all means the chances that one kid is going to be infected and give it to another kid goes way, way, way down. So if you want to protect kids in a community, get the adults vaccinated. And the data from Israel on this is clear. The data in the United States is clear. The data on the UK is clear. Like, when adults get vaccinated, infection numbers among kids drop. If infection numbers on kids drop, then they can't be giving it to each other because they generally don't have it. All right, that's one part of it. Let's flip to the specific scenarios that were asked. What do you do in the office environment? If everybody in the office environment is vaccinated, you, let's say, have a kid at home. I have a kid at home who's 9, right? I'm not going to pick up the infection from somebody else, because vaccinated people spreading it to other vaccinated people happens. It's exceedingly rare and requires a bunch of things to happen. And the single biggest thing that needs to happen is you need to have symptomatic disease. So asymptomatic spread of the virus, which is very common among unvaccinated people, doesn't happen among vaccinated people, not that we have any evidence of. So imagine the scenario of you're hanging out with a colleague at work. They're vaccinated, but they're asymptomatic carriers. Maybe they picked up the infection somewhere. Doesn't happen that often, but could. Could they spread it to you? Like, insanely unlikely. Just have never seen a case of that. Then could you, so that's one thing that we've never seen. And then the idea is that you'd pick it up and then you spread it to your unvaccinated child. You know, at some, like, these are risks that get well below like risks of getting hit by lightning, we're talking about things that are exceedingly unlikely. The one scenario, the Yankees scenario, what happened with the Yankees was basically you had a person who had breakthrough infection. He was really quite symptomatic, coughing, fever. And then he spent 4 hours unmasked in a small room with 10 other people. So if you have a colleague who shows up to the office, febrile, hacking up a lung, coughing all the time, tell that person to put on a mask and go get tested, right? Like, don't hang out in a small room with that person for 4 hours. But I think that's just good common sense. That's the one time we've seen. And then, by the way, when he spread it to a bunch of Yankee players and coaches, they were all asymptomatic. None of them got sick. And none of them transferred it to anybody else. So it is a bit of common sense, but asymptomatic spread among infected. Let's just do one more scenario. What about the workplace that doesn't require it? That's far more tricky, and we just have a lot less data, and I'd be much more concerned. And one of the reasons why I have pushed for Brown to be a place that does require it is because I want to create, again, that sort of ring of safety that makes it for our family members, let's say, who are kids who are not vaccinated or maybe immunocompromised. One of the best ways of protecting them is by being in a fully vaccinated environment. So unvaccinated workplaces, I think, are a little bit trickier. I still think you're probably pretty well protected if you're vaccinated in terms of not spreading it to your kids, but it's just probably a little bit of a higher risk.
Thank you. And so to just like put that kind of final fine point on it, asympt spread, if you are vaccinated, chance of you're spreading it to someone else is so low. Like if you take, that was great, Ashish, a terrific kind of going through of all those different scenarios. Thank you. I know there are other kid questions out there, guys, and I will try to get to some of them, but I want to go on to some of the other topics that people have been submitting a lot of questions about. I do see some of you boosting questions in the chat, not ignoring them, just making my way through. So the next group of questions, Ashish, that we've gotten a lot about is about the vaccines and the variants. Mukul, Jillian, Suchitra, Jackie, all ask how effective and protective are the vaccines against novel variants, quoting, variants from various different countries. Would love to have you speak a little bit about that.
Yeah. So think of your immune system as a multi-layered defense system, okay? Nature is an amazing thing. And by the way, vaccines, just to be very clear, the vaccine is not protecting you. Your immune system is protecting you. The vaccine is getting your immune system ready to protect you. That's what the vaccine does, is it primes your immune system. It uses your immune system to get it ready to protect you from the virus, right? So what is happening with these vaccines? And again, I have to say, I remain amazed at how much more effective these vaccines are than I would have expected if we were here a year ago, or even back in August or September. These vaccines generate a multi-layered defense, and this will then get to the variants, I promise. They generate antibody response. Everybody hears about antibodies. Antibodies are really, really important, like really, really important. They generate memory B cells, which kind of hang out. They're like what they sound like. B cells make the antibodies. Those B cells can hang out. You may not have a lot of antibodies, but if you encounter the virus, they can generate antibodies very, very quickly. They generate T cell responses, CD4 and CD8 T cell responses. T cells, and again, there's a lot of complexity in immunology, and I'm going to simplify it in a little bit of a simple way. T cells really are what we often think of as cellular immunity. They are a very, very powerful and different level of defense. And this will get to the Johnson & Johnson vaccine, which produces a phenomenal T cell response, but maybe a little bit less of a powerful B cell and antibody response. And that's why you tend to see with J&J a little bit more in the way of breakthrough infections, but the level of protection from severe disease is awesome in J&J. And so there are two sets of things to think about. If you have variants that have immune escape, 351 originally from South Africa. It's a little bit of evidence around 6172. That's one of the variants from India. P1 that was originally found in Brazil. All of these have a little bit of immune escape. What that means is you're going to see a few more breakthrough infections. But what you really, really care about is two things: preventing that from turning into large outbreaks and making sure that you don't really get very sick. And the breakthrough infections are happening because the immune escape is beating the antibodies a little bit. You get less neutralization. But your T cells are right there, and they're preventing you from getting really sick. So all of the data suggests so far that our immune system is phenomenal. The vaccines train our immune system to be phenomenal at preventing you from getting very sick from all the variants that are out. But some variants cause a few more breakthrough infections than others. Again, nothing is 100%, so we will still see some breakthrough infections leading to people getting very sick, but those are exceedingly, exceedingly rare. So big picture, variants are bad. Some of them, many of them are way more contagious. 117, the one from the UK, super contagious. Increasing data suggests that 6172, one of the variants from India, is probably way more contagious than the UK variant. And that's a real problem in terms of causing infections among unvaccinated people. Vaccines hold up really well against those. The other variants that cause a bit more immune escape, we do see some more breakthrough infections, not a lot, and those people still don't get sick. Your immune system holds up. That doesn't mean that we will never have a variant that causes more breakthrough infections or even begins to cause a lot more severe illness. I'm relatively hopeful that they won't, but it's a bit of like relatively hopeful that in the future is not like the most reassuring thing I can tell you. And like the best way to prevent that nightmare scenario is we got to get the world vaccinated. So that's where we are.
I love it. Thank you. So that's going to lead me to two next topics. So one is around, you've mentioned kind of those antibodies and antibody tests. And then I'm also going to ask a little bit, there've been a bunch of questions about getting the world vaccinated and then travel. So just to give you a sense of, to give all of you a sense of where we're going next, those are kind of the three next big topics. So antibodies first. Had a bunch of questions, Jeff, Emily, David, Lauren, about antibody testing. Is there an advantage to having a post-vaccination antibody test? And relatedly, does having antibodies from a prior COVID infection mean you don't need to get the vaccine?
Two good questions. So first, on the first question, no, don't get antibody tests after your vaccination, largely because you won't know how to interpret it. And there are a couple of reasons. So you say, well, what do you mean? Why wouldn't I know how to interpret it? First of all, almost everybody generates some. And there are some very, very immunocompromised people who may generate no antibodies. We can talk about immunocompromised people. In the end, you have to talk about really severely immunocompromised people. But what we don't know is which antibodies matter the most for preventing infection. So you may have antibodies, but they may not be the ones that matter the most. You may not have much in the way of antibodies, but they may be the ones that matter. So we just don't understand it. And there's a lot of science happening here. I may change my answer in 3 months. I probably will, because I think we'll know a lot more. But as of today, I wouldn't do it, mostly because I wouldn't know what to do with that answer, right? So that's kind of the first thing. There are there are scientific labs that are like working on this, and I think we will sort this out. Second is there is very good evidence, and I think Megan alluded to this earlier, that if you've been previously infected, first of all, you have some real protection. So no doubt about it. Second is there's a couple of studies that say it may be out to a year, but most of the studies suggest it's probably out to 6 months. Third is there's pretty good data that just one shot of one of the mRNA vaccines is probably good enough. And a bunch of us have actually tried to lobby the FDA and NIH to really think about letting people who've been previously infected and documented previously infected, not I think I had it back last March. That doesn't count. To get away with one shot. So far, FDA and NIH are holding tight that they don't want to go to one shot only for those people. And my take is, I got to convince them, and if they're not willing to buy it, then we should continue following the protocol. But there's pretty good evidence that if you've been previously infected, you may only need one shot. But right now, this policy is 2, and that's what we should go with. And last but not least, the question I get asked a lot, and Senator Rand Paul of Kentucky basically was like, I'm not getting the shot because I've been previously infected. So why bother? Tell you why bother. I think there's pretty good evidence at this point that vaccines probably give you more durable immunity. Your immunity will last longer than if you've been just previous infection, and they give you broader immunity. These vaccines are remarkable, and I know I keep saying that over and over again. They really are remarkable. They generate a broader set of immunity than just having been previously infected. It's counterintuitive to a lot of people. They think, well, how can having been exposed to the virus give you less immunity? It turns out the virus, the real virus, when it infects you, has all sorts of mechanisms it uses to try to hide itself from your immune system. And so while your immune system is still able to manage it, it doesn't get the full exposure. With mRNA vaccines and the Johnson & Johnson vaccine, they expose a lot more epitopes. They give you a much broader set of immunity. So all of the evidence right now says you have better immunity if you've been vaccinated than if you've been previously infected alone. The two together probably give you the best immunity, but you get fabulous immunity from just the vaccine. And that's why I've been pretty clear that people should get vaccinated. And that's where the policy is as well.
I love it. And don't go get infected just to increase your immunity, please.
Correct.
Even, yes, I was waiting for Apurva to put that into the New York Times article and it just didn't make it. But all right, I'm going to ask, I know that we're getting close to the end of time here, so I'm going to apologize in advance to folks whose questions I don't get to. There are so many incredible questions here. Hopefully most of you will get answers to at least some of these. I am going to skip the questions that are more general about the public health response. So I know a lot of you have put in questions about masking in general, about CDC, about global vaccination efforts. I'm just, for the sake of time, going to skip those because I really want to dig a little deeper into some specific things around the vaccines themselves. And we'll hopefully touch on some of those topics another time. So the next kind of group of questions, Ashish, that I'm going to go to is around travel. A lot of folks are wondering, what is safe for me to do regarding travel if I am fully vaccinated? Can I travel domestically in the US? Can I travel internationally? Mukul, Ani, Mark, Vedant. This is Angela. It's particularly being asked about folks who are either international students or who are part of our kind of international study community. Yeah. What do you recommend?
Yeah. So I'm speaking for myself and the science, and I know the university is working on policies on this. Domestic travel is totally fine. You want to go somewhere in the US, go. I haven't yet, but I think probably in the next month I will change. And I haven't yet mostly because just I wasn't looking for travel opportunities in the last year and a half. But I probably will, and I think it's totally fine. And I expect that we'll see policy updates around that. It's relatively soon. Follow CDC guidelines, of course. CDC continues to ask people to mask up during domestic travel, interstate travel. I think that's completely appropriate, and so we should do that. But I think domestic travel is fine. International travel is tricky because it turns out international is like not a destination, right? International travel includes everything from going to Toronto to going to Delhi, to going to Hong Kong or Sao Paulo. And international travel is completely dependent on where you're going. First and foremost, like there's a whole bunch of State Department policies and they're all changing. So you got to follow that. Like that's the no-brainer part of this. Can I imagine that in like June or July, it might be reasonable and safe to travel to London? Yeah, probably. Again, we don't know what the policies are, and I think Americans are going to be allowed to be let in more and more. But I think we're going to see international. Would I go to Mumbai right now? I would not. And not just because, well, I'm fully vaccinated, but also there's some challenges when a country is going through a really horrible outbreak. Their health system is overwhelmed. Like you could fall down the stairs and break your arm and need hospital care and not get hospital care. So even if you're fully protected from COVID, vaccines don't protect you from broken arms, right? Like so you may still need a functioning healthcare system. I would not travel anywhere where there's a large outbreak happening because those health systems are really struggling. And I don't think that we need to be adding to the stress to that health system. There are going to be some rules about coming back and getting tested. I do think vaccines are relatively safe for international travel, but there's a lot of complexity and you really have to decide based on how badly do you need to go, where are you going, what are the local kind of circumstances, and how easy would it for you to get back. But if you're fully vaccinated from a safety point of view, it's probably pretty okay.
Thank you. I appreciate that. And I do just, as an ER doc, I just want to emphasize, right, that was our concern at the beginning of the COVID pandemic here in LA, elsewhere during the biggest parts. Don't overwhelm the health systems in other countries that are dealing with outbreaks. But that's lovely, and thank you. And hopefully that puts a lot of minds at ease. So I think I'm probably going to have a chance to go through two more questions. And if we get through both of these, I'll do some quick kind of back and forth yes, no answers. But these next two questions, I think, require a little more discussion. One from both Eugene and Andrea is, if the FDA full approval is right around the corner, why mandate EUA version with a seemingly arbitrary date of July 1st? What if people are waiting for full FDA approval because they feel more comfortable with that?
So this is a policy question that ultimately I think can be, I wasn't involved in the policy, but I fully support it. So I'll give you my case for it. Okay, and I'm not speaking as a senior officer of Brown, but I am speaking for myself, and I think the policy was right. I think the question is, to me, these decisions should be made based on science and data. And if the FDA had fully approved it, but the data wasn't there, I wouldn't support it. And I wouldn't say, well, the FDA has approved it, so we should do it. And if the data is there and the science is very, very clear, even if the FDA is taking a few more weeks, that's up to them. I think we should move forward. The data, so first of all, the chances that Pfizer is going to get full approval is well north of 99%. Like, it's hard for me to think about, like, what would it take for the FDA to deny it? And I can't come up with it, just because the data is so overwhelmingly clear. These things often take 6 months or a year because there's usually no rush. There's not much of a rush. I think this will move faster because, again, we're in the middle of a national emergency. But FDA also doesn't feel a huge rush because they're like, people are getting vaccinated anyway. So, like, why do we need to make this a thing? So you may end up getting a delay. You can easily imagine there's some questions back and forth that delay this by 3 months. I don't think the university is going to want to let FDA delays drive it. So if they delay it by 3 months and all of a sudden we're into October, November, we've lost the fall semester. So my sense is what we should do is we should do this based on data and science. And the data on this is so overwhelmingly clear that I think the university made the right decision. That people have brought up legal issues. I have said in the past, I am like nobody's definition of a legal scholar. So I don't know what I would generally avoid commenting on it, but I know a lot of legal scholars. A lot of people have weighed in and said the universities, private entities, are well within their rights to do so. The Equal Employment Opportunity Commission has come out and said as much from the government. So I think it's very reasonable. Ultimately, I want to do what I think is right and not be delayed by, imagine FDA had said, we'll try to make a decision by July 1st. And then something happened and they said, actually, we're going to delay the decision until September. We don't want to be beholden to that. We want to let the data drive it.
Thank you. I really, and just to not to like overemphasize that, but that point of the difference between the full authorization and the EUA is so minimal at this point. There is going to be no additional data accumulated that's going to change things. It's been, especially for Pfizer and Moderna, right? How many? 150, what's the current count on, like 150 million doses administered across the US?
Yeah, it's about 280 million doses.
280 now. Yeah. Thank you.
160 million people.
Okay, final potentially question here is around vaccine confidence and how we have conversations with family members, with friends, with community members, with neighbors. There are so many folks who have asked this, Stephanie, Imran, Rosa, many others. What would be your suggestion about the best way for us to improve vaccine confidence among our friends and family circles?
It's a great question. So these are deeply personal things for people, and people have strong feelings. And my general approach, I've spent years talking to people about vaccines, about medicines, and there are a few principles. First is hear people out, listen to them. Don't dismiss what they have to say. Someone brings up the issue of fertility, don't roll your eyes and say, oh my God, that's just junk. Like, hear it out. Respect, understanding goes a long way. Second, it is about trusted voices. For your family and friends, you are a trusted voice. It is about, when I talk about vaccines publicly, I talk all the time about what I do for my family, right? Why do I do that? Because what I'm trying to convey, and turns out to be true, is I'm trying to convey to people that, like, look, I can say whatever I want, but if I act differently, like if I'm like, oh, but I'm not getting my family vaccinated, then you're not going to trust what I have to say. And so part of it is also leading with personal experience, helping people understand what you've done and why. And third, see these as long-term projects. It is the very rare instance. I've had it once in my life where I actually persuaded somebody about the flu vaccine over the course of a dinner. But that took like 2.5 hours. And I feel like I got super lucky. This is not a one conversation. You talk to a family member once, and at the end of it, they're gonna be like, okay, fine, I'm getting the COVID vaccine. See this as a project and see it as a long-term engagement where you're gonna wanna help people get more comfortable and more confident. I do think, first of all, 62% of adults have already gotten their first shot. I think we're gonna get into the 70s. without too much difficulty. Here in Rhode Island, we're at 72%. In Massachusetts, we're at 73%. So we're cooking. We're going to get into the 80s in these states. But we just got to keep helping people understand the information, answer their questions, deal with people with respect, and I think that goes a long way towards helping people get there.
Thank you. And for those who are interested, there are lots of resources out there. What would be some of, Ashish, kind of your recommendations for people's top resources if folks want to remind themselves about some of these facts and figures to help combat misinformation or to answer their family and friends' questions? Are there certain sites that you would send them to?
That's a good question. I mean, my initial inclination is CDC as sources of good information. CDC has good information. But we're actually working on, and one of our colleagues, who many of you may have encountered, who's new to Brown, Stephanie Friedoff, has been doing a lot of work on this, on trying to really work on what kinds of communication and information is helpful. I would turn to Meg and Ranney for advice on this. And so, Meg, do you have where do you send people, or what data sources do you look at?
Yeah, it's a great question. So there's the Ask Pandemic website, which has some really, really good questions and answers that I love. I'll often send people to WebMD or to Medscape, which have some nice resources. AAMC has some collations of resources that I know that you and I both have been involved with helping to create.
Yep.
And then there's some specific resources for minoritized communities. There are kind of equivalents of the Ask Me Anythings for Black and Latinx communities, which can provide nice resources. There are Spanish translations. There was just a nice interview with Rhea Boyd, who's a fellow physician. Alice Stanford has done nice work. Maybe awesome. We can send, I wonder if maybe we can collate some of these and send them out afterwards to folks.
We can do that.
And then Stephanie just put some lovely tips for talking to family members and friends in the chat around that we could include as well to help you guys. So last question, and this was not a question in here. And folks, again, apologies. There are so many brilliant thoughts and questions and very specific personal concerns. But last question for you, Ashish, is, are you hopeful?
Super hopeful all around. Let me say a couple of things. One is, this literally is a once in a century event. By the way, we should not assume this is going to remain a once in a century event. We are going to have more of these kinds of crises. A lot has gone wrong in our response. A lot of misinformation, a lot of disinformation, a lot of shenanigans in the public health response. But a lot went right. And the way the scientific community, not just in the United States, but around the world, pulled together is nothing short of extraordinary. I do think we have clearly turned the corner in the United States. We will never go back to the kinds of, for this pandemic, never go back to the kinds of infections and suffering we saw in the fall and winter. We're not completely done. We're going to have to continue to manage this virus for years, but it will become in the background. And it will be something we just manage and deal with and live with and get on with our lives. And that's much, much sooner than most people realize. There is a huge global problem. What I just described for the United States is true for the United States and a small number of other high-income countries. It's not true for the world. And so there's a lot of attention, energy, work being done. A bunch of us are spending a lot of time these days trying to figure out, how do we really move on the global vaccination front? And this is incredibly complicated. There are no simple solutions, and a lot of people are working on this. And I'm actually hopeful on that front as well, that we will make a lot of progress in 2021, and that my hope is early to mid 2022, so less than a year from now, we will have maybe a majority of the world vaccinated. That's among the most optimistic timelines that I've seen, but I remain confident. I remain optimistic that we'll be able to do that. And then we got to make sure that as we pull out of this pandemic, that we don't just sort of say, oh, thank goodness that's over, and move on. We do two sets of things. One is we work on what it'll take to prevent and manage future pandemics. But second, that we use this public health moment to think about all of these huge health challenges that this pandemic has revealed. And some of them are not inherently health in underlying, but have huge health manifestations, such as structural inequities and racism in our country, issues around opioid use and disorders. I'm not going to list them all. But the point is that there are opportunities for us to begin to address some of these things in a much more concerted way. And that gives me optimism, because those issues have been with us for a long time. We've not been able to move on them. And I'm pretty optimistic that we will have the opportunity to do so. So we're going to get back. We're going to have a pretty good summer. We're going to have a normal-ish fall at Brown. It's going to be wonderful. And we'll be able to put this pandemic in the rearview mirror sooner than we think.
Thank you. Well, with that, thank you all for joining us. I think we had 322 people at the max, as has been put into the chat. The transcript and recording will be available. We'll be putting together an information sheet. Thank you guys all for joining us, for coming with your honesty and with your really thoughtful questions. It's just an honor to be part of this community and to see us all as voices for truth and for helping to protect each other. So thanks for joining us.
Yeah.
Have a wonderful afternoon.
And
Thanks,
Megan,
Ashish.
thank you for moderating, and be well, everybody. Stay safe and get vaccinated. Talk soon.
Bye, everyone.
Bye-bye.